Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today I'm flying solo. This is a new series from the podcast crew here at MCHD, and we've tentatively titled this one The Med Minute. We're going to create some short and sweet pharmacology-based episodes for meds that we actually use here in the service in Montgomery County. High-yield stuff that you can take with you out on your shift every day. Thankfully, a lot of medications we use in EMS here in Montgomery County are regional, nation, even worldwide. So for all the non-MCHD listeners out there, hopefully these will be useful as well. We are going to start with one of my favorite medications in all of emergency medicine. Just the varied usage, indications, the history, the simplicity make it a real Swiss Army knife, and the med I'm speaking of is magnesium sulfate. And I like to use mag in my own emergency department practice. I learned quite a bit from doing a little bit of background research for this podcast. And, mag has been used for preeclampsia for over 100 years. So it's been around for a literal century. If you want to go look up something that will confuse you, maybe put you to sleep, Ambien via words, look up mechanism of action of magnesium. No one really knows. It's involved in the ATP cycle, so generation of energy, very important there. DNA, RNA, protein metabolism and synthesis, vital cell functions, smooth muscle relaxation, cardiac and neuronal conduction, insulin metabolism. So many functions within our body are impacted and facilitated with magnesium as a cofactor. It is the second most common cation or positive ion in our body. Number one is potassium. Number two is magnesium. Normal lab value for magnesium is 1.7 to 2.4 milligrams per deciliter. There's a little ER knowledge for the EMS listeners out there. We have about 25 grams of magnesium in our body at any given time, primarily located and stored in our bones. So just a little history and mechanism or mechanism muddiness. Let's talk about indications. We have varied indications on the truck for magnesium. I'm going to talk about the truck first and later on talk a little more about the emergency department uses of magnesium because there's even more for me as an ER physician. But on the truck here at MCHD, we use magnesium for asthma and COPD, obstructive lung disease in both adult and pediatric patients. We use magnesium for preeclampsia and eclampsia in pregnant patients. We also use it in cardiac arrhythmia patients who have stable polymorphic ventricular tachycardia, and also as an adjunct in refractory ventricular fibrillation. And if you think about some of those mechanism of action potential spots for magnesium, all those uses make sense. Asthma and COPD are thought to be aided by magnesium through smooth muscle relaxation effects. Preeclampsia and eclampsia are also thought to be helped by magnesium's vasodilatory properties. Magnesium is also a calcium blocker for the most part. Potentially some NMDA receptor effects for preeclampsia and eclampsia. The honest answer to that one is we don't really know exactly how it works for those conditions, just that it does. And then for torsades or polymorphic VT and refractory VF, the cardiac conduction effects of magnesium is where our benefit arises from in those conditions. Dosing here at MCHD, again, as always, refer to your own service protocols if you're a non-MCHD listener. For the MCHD folks, our asthma, COPD, obstructive lung disease dosing, 2 grams IV. Polymorphic ventricular tachycardia, refractory VF, also 2 grams IV. For the pediatric dosing indications in those spots, please refer to hand-heavy. Preeclampsia and eclampsia receive a higher dose of magnesium. We recently made a protocol change increasing our preeclampsia and eclampsia magnesium dose to 4 grams IV. That may sound significant, we doubled it. Oh, wow, doubling of the dose. If you want to really see some impressive magnesium doses, hang out around the labor and delivery unit. They mix their magnesium in gigantic bags and give enormous amounts. So even in the world of obstetrics, a 4-gram dose is very much a BB gun when we start to think about the amount of magnesium that we're giving at 4 grams. Contraindications, there really are no true absolute contraindications beyond history of anaphylaxis, which I believe would be potentially impossible considering it is a cation that exists in our body. When I initially created this episode and wrote our outline, I had a sentence in the outline that generated some discussion around the office, and that was used with caution in end-stage renal disease. And one of the clinical folks said, "What do you mean, doc, use with caution? In EMS, we either use it or we don't use it. You have to remember you're in protocol world here." And it was a really good point that was made. And so from the standpoint of a paramedic in a truck giving magnesium, if the patient is in severe enough asthma /COPD exacerbation to warrant magnesium, if they are in preeclampsia or an eclamptic situation, if they are in stable polymorphic VT, and by all means refractory VF, ESRD is really not a contraindication at all, and it's not something we would be cautious with. We would just use a dose of magnesium at 2 grams or 4 grams, depending on the indication. When we talk about use with caution in end-stage renal disease, that really applies more to hospital-based physicians, emergency physicians, nephrologists, hospitalists, intensivists who are giving magnesium doses over time. Why do end-stage renal disease patients matter? Because they don't clear magnesium, and magnesium toxicity is easier to occur in those patients. So for the medics out there, if you are in a mag situation, other than a history of an allergy, which I don't believe is something that could theoretically happen, but you never know. I always say around the office and even in the emergency department, 2 words I try to avoid at all times are always and never. So no real contraindications to speak of, but there are some side effects with magnesium toxicity: loss of reflexes, progressing to respiratory depression and muscular paralysis, into arrhythmia and cardiac arrest. Common OB question around the L&D unit: if a patient is exhibiting magnesium toxicity, they happen to get an overdose or an incorrect dose of magnesium, what is our antidote? Our antidote is calcium. Magnesium is a calcium blocker. Calcium is a magnesium blocker. There are some non-EMS uses to wrap up our discussion today that I may and often do use magnesium for in the emergency department. Some of these are things that I've never treated that I'm not sure that I really want to, but let's run down the list of some non-EMS magnesium uses and we'll wrap it up. Atrial fibrillation, neurocomplex tachycardias. There have been multiple studies over the past decade looking at magnesium in the field of rate control for rapid neurocomplex tachycardias, both as a primary treatment and as an adjunct. The data there, not to go off into the weeds too far, is conflicting at best. I tend to use magnesium in conjunction with my other rate control agents when I'm preparing for cardioversion and also when I'm attempting pharmacologic rate control. It's not a panacea, it's not gold standard, but in my opinion, in my practice, a useful adjunct treatment. There are multiple recent studies from the emergency department world looking at magnesium as an analgesic for pain control in conditions such as migraine headache, also in renal colic. These are 2 areas where I don't use magnesium very often. I've not used it in renal colic. I use it in migraines 2nd line to 3rd line when patients are difficult to control. I will add it on, not as a last ditch, but really as a secondary, tertiary option. one of the most common ward questions that I've heard over my career in the internal medicine wards out in the hospital, not in the emergency department, involves hypokalemic patients and treating low potassium. And magnesium gets involved in this question because it assists the gut with potassium uptake, and it also can increase kidney potassium excretion when magnesium levels are low. So if you find a patient with a potassium level of 2.9, which is a hypokalemic situation, often folks will give magnesium with the potassium, check magnesium levels, because without replacing your magnesium, your body is not going to absorb and hang on to potassium. So if you see a potassium of 2.9, the question often is, what lab do you need to test? And it's a magnesium level. What medication do you need to give? It's usually not potassium first, but it's supplementary magnesium sulfate. Lastly, for the out there indications for magnesium sulfate, one that I've never seen or treated, but definitely interesting when looking at magnesium uses. It is used as an antidote, a pain treatment for the jellyfish sting from the irukandji, which is one of the more, if not the most painful jellyfish sting in the world. And these are little tiny, sometimes difficult to see with the naked eye, organisms that live in the waters off of Australia. So if you need another reason not to get in the ocean in Australia, the irukandji is definitely one. These are just painful beyond belief, so much so that they've been actually reported to cause patient deaths. And there have been trials utilizing magnesium for irukandji stings. The trials are small. They're not terribly well blinded or randomized, as any treatment would be in a situation, in a treatment that's so rare and rural and uncommon, thankfully. But I thought it was interesting that even down under in Australia with the irukandji jellyfish, that magnesium has been proposed as a treatment for pain and for prevention of progression of this awful, awful jellyfish sting. So let's wrap it up. Magnesium sulfate, been around for 100 years. Second most common cation in the body next to potassium. 1.7 to 2.4 milligrams per deciliter is our normal lab value for magnesium levels. It works in a multitude of ways: ATP cycle and energy generation, DNA, RNA, protein synthesis, smooth muscle relaxation, cardiac and neuronal conduction. All of these mechanisms help to explain why we use it in asthma and COPD. Bronchodilation, smooth muscle relaxation, preeclampsia and eclampsia, vasodilation and potentially calcium channel blockade, stable polymorphic VT or torsades, refractory VF, cardiac conduction. Our doses, 2 grams IV in our cardiac and obstructive lung disease cases, 4 grams IV in preeclampsia and eclampsia. In our pediatric patients, utilize hand-tevi. No true contraindications in the pre-hospital setting. If you ever get a test question on side effects, loss of reflexes, respiratory depression, paralysis to arrest, with the antidote being calcium. Hopefully you like the Med Minute. We'll keep these short and sweet episodes coming. Try to hit some of the most recent medication changes here in our MCHD protocols and our most commonly used medications. As always, if you have questions or ideas for future episodes, please hit us up at podcast@mchd-tx.org. Please follow us and subscribe wherever you listen to podcasts. Follow us and subscribe to our YouTube channel as well if you're a YouTube watcher. If you're not, check it out. As always, thanks for listening. We love our listener feedback. We love that you guys join in for all of this learning and for the length of time that we've been doing this. We'll be back with a new episode soon. Thank you very much. Have a great afternoon.